Hello and welcome to today's class. Today we are going to discuss the investigations, treatment, complications and prognosis of meningitis. In my last class, I have discussed the basics of meningitis including the clinical features. So let's start with the investigations, and the gold standard investigation is lumbar puncture, which should be done before the antibiotic is started. But before doing the lumbar puncture, you should remember the contraindications. If there is a contraindication, then you should not be doing lumbar puncture. So absolute contraindications are raised ICP, that is Cushing reflex, severe cardiopulmonary compromise if the patient is in shock, infection of the skin overlying site of lumbar puncture, and if there is focal signs which suggest the intracranial space occupying lesions. And relative contraindications are thrombocytopenia with platelet less than 50,000 per cubic millimeter and low GCS, that is less than 8. So in these conditions you should not be doing lumbar puncture. Lumbar puncture can be done in a lateral position like this, with the knee, hip, head flexed so that the intervertebral space is increased, or in a bigger children you can even do in a sitting position like this, and the child is flexing the neck. Always do random blood sugar 30 minutes before doing the lumbar puncture, because you have to correlate the level with the random blood sugar. The CSF sugar and random blood sugar should be correlated to see whether it is a low sugar or not in the CSF. So initially you clean the site. The site to do lumbar puncture in children is lumbar 4 and 5th intervertebral space. If you don't get in this space, then you can go one space above at L4 and L3. And after taking out the fluid, the tube 1 you send for cell cytology and the differential counts in the pathology department. Test tube 2 you send to microbiology lab for gram staining and culture and sensitivity. Tube 3 goes to biochemistry lab where they analyze the glucose and protein of the CSF. And number 4 tube is kept for several purposes, and many places they do Japanese encephalitis serology with this tube 4. So every tube should be containing at least 0.5 to 1 ml of CSF when you have CSF sample when you send for the analysis. Now let's see the different findings of the CSF: normal, viral, bacterial and tuberculosis. These three are important, and normal finding is always important. So pressure normal is 50 to 80 millimeter of water. So in viral it is increased to 80 to 150, bacterial 100 to 300, and tuberculosis also increased. Appearance is normal to clear in the normal condition and viral pathology. If it is a bacterial pathology, the CSF is turbid, and tuberculosis it can be straw colored, or if you keep the CSF for 24 hours, there is a cog wave formation in the CSF sample. And the WBC normal is less than 5 cubic millimeter, where more than 75% is lymphocyte. Viral, the WBC is 500 to 1000, and then lymphocyte is predominant, whereas bacterial it is 100 to 10,000, and then predominantly neutrophils are found, and tuberculous less than 500, and then lymphocyte is predominant. And the glucose is in normal condition more than 50 milligram per deciliter, or 75% of the blood sugar. Viral pathology is normal glucose finding, except in moms it might be less than 4 milligram per deciliter. And then bacterial it is less than 40 milligram per deciliter, or less than 50% of the blood glucose. And the tuberculosis also less than 50 milligram per deciliter. Protein 20 to 45 milligram per deciliter is normal. In viral 50 to 200, bacterial 100 to 500, and then tuberculosis it is more than 100 or even it can be up to 3000 milligram per deciliter. The protein level is very high. And if you do a gram stain, you get a positive pathology or microorganisms in 60 to 90% cases of bacterial meningitis. Now come to some other investigations which can also support the diagnosis of meningitis. You can do, but these are all non-specific investigations. So you can do CRP, ADA, LDH, lactic acid in CSF to differentiate whether it is a pyogenic or non-pyogenic meningitis. Then you can do complete blood count, peripheral smear, blood culture, serum electrolytes, blood glucose level, ESR, CRP, skin scraping for culture sensitivity, where required X-ray chest, and then even if the patient is very sick, ABG is sometimes required. For rapid diagnostic test, you can do PCR, polymerase chain reaction, or latex agglutination test or an ELISA to detect the antigen antibody. Then neuroimaging is not a routine investigation that is done, but in certain conditions it is indicated. So conditions where the neuroimaging is indicated is signs of raised ICP with the papilloedema. If you are suspecting malignancy with the focal neurological deficits, and deteriorating neurological status, that is GCS if it is less than 12, status epilepticus if the patient is having focal neurological deficit. Now come to treatment. You should start antibiotic empirically and then don't wait for the culture reports, because culture is going to take at least 72 hours. So empirically you should have to start antibiotic if you are suspecting meningitis. Start as soon as the lumbar puncture is done, except if it is contraindicated, then regardless of LP you should start antibiotic. Treatment for raised ICT and other complications are other modalities of management. Let's see the antibiotic empirically what you can start. So if the organism is unknown initially before the culture report, you can start with the ceftriaxone with dose 100 mg per kg per day, cefotaxime 200 to 300 mg per kg per day, ampicillin 300 mg per kg per day, or penicillin G and chloramphenicol combination is used with penicillin 4 lakh unit per kg per day and chloramphenicol 100 mg per kg per day. So these are the various options you can select, and the duration is 10 days if the organism is unknown. And if you suspect meningococcal meningitis, then choice of antibiotic is penicillin or ceftriaxone. So penicillin dose will be 3 to 4 lakh unit per kg per day, with ceftriaxone 100 mg per kg per day, and duration of treatment should be 5 to 7 days. Pneumococcus, if you suspect, then penicillin G is the drug of choice, or if it is patient is resistant or sensitive to penicillin, then you can go with the combination of ceftriaxone with vancomycin. Vancomycin dose is 60 mg per kg per day. Duration of treatment for pneumococcus is 10 to 14 days. Haemophilus influenza, ceftriaxone, cefotaxime is the drug, and the duration of treatment is 7 to 10 days. If it is a gram-negative organism, then ceftriaxone, cefotaxime with the aminoglycoside combination is used. Duration of treatment should be 21 days. If it is Pseudomonas, then ceftazidime and aminoglycosides are the drug of choice combination. Ceftazidime dose should be 150 mg per kg per day. Duration should be 14 to 21 days. Cephalococcal organisms, vancomycin is used with a dose 60 mg per kg per day. Duration should be long, so that is 28 days. And penicillin sensitive Streptococcus pneumoniae, you use ceftriaxone, cefotaxime, or IV penicillin G or piperacillin, and the duration of treatment is 10 to 14 days. In neonates, the antibiotic of choice is ampicillin with amikacin or gentamicin, or ampicillin with cefotaxime combination is used. Immunocompromised patients, ceftazidime aminoglycoside or ceftazidime meropenem is the choice. Listeria monocytogenes, T lymphocyte deficiency, ampicillin is a drug of choice. Allergic to beta-lactam, antibiotics, chloramphenicol is the choice. And all these conditions, duration of treatment is 14 to 21 days. Now, role of steroid. So, steroid is indicated and that should be given before the antibiotic is started. So, the rationale why you use steroid is antibiotic rapidly kills the bacteria in the CSF. There is a cell lysis of bacteria and then it releases toxic products. And then it enhances the cytokine mediated inflammatory cascade. There is formation of edema and neutrophilic infiltration leading to neuronal injury. So anti-inflammatory therapy is done with the dexamethasone 0.15 mg per kg per dose every 6 hourly for 4 days. And then first dose should be given prior to first dose of antibiotic. The benefit of steroid is it limits the production of inflammatory mediators and reduces the incidence of cytokine related damage, that is mainly the 8th nerve damage, which leads to sensory neural hearing loss. And then internal hydrocephalus is prevented, decreased intracranial tension, and then behavioral disorders, which is a sequelae of meningitis, that is also decreased by giving steroid. And just remember, there is no role of steroid in the neonatal meningitis. It is useful only for children more than 6 weeks where you suspect the Haemophilus influenza and Streptococcus pneumoniae. These two are the main organisms leading to all these complications, and sometimes also tubercular meningitis. So these organisms are not common in the newborn. So neonatal meningitis, you do not give the anti-inflammatory treatment. Now come to the supportive treatments. So fluid therapy, if the patient is in shock, then you give a bolus resuscitation. Preferred solution is 0.9% sodium chloride with a 5% dextrose. Newborns may require 10% dextrose. And then with that you give a vasoactive agents. If you suspect SIADH, that is syndrome of inappropriate ADH secretion, then give 2/3. You have to restrict the fluid to 2/3 maintenance. Keep the patient nothing per oral, and then oral feed should be started once the patient is stable. For the raised ICP, head end elevated to 30 degrees, and then you can give IV 20% mannitol 0.5 to 1 gram per kg 4 to 6 hourly. Maximum 6 doses can be given, or you can even use 3% saline. And then IV furosemide is other option. Glycerol acetazolamide can be used, and the restriction of fluid 2/3 maintenance. If there is seizure or convulsion in meningitis, then IV diazepam, olorazepam for the immediate control, and then followed by you load with the phenytoin 20 mg per kg per dose, and then followed by maintenance 5 mg per kg per day. And if there are metabolic abnormalities like metabolic acidosis, hyponatremia, hypokalemia, hypocalcemia, hypomagnesemia, they should be corrected. Other supportive measures are monitoring of the pulse rate, respiratory rate, blood pressure, all the vitals. Do the intake output charting, monitor the serum electrolytes 12 hourly. Head circumference should be measured if the children is less than 18 months. And then fever, if there is fever, use antipyretic or cold spongings. And then feeding is continued even with the tube feeding. If necessary, you have to give. If the patient's sensorium is normal, then you can go with the oral feeding. Then care of the position, oral cavity, eyes, bladder, bowel and skin, all these are important. Now come to complications. Treatment of complications. If there is subdural effusion, aspiration can be done. Hydrocephalus, then you have to do the shunt operation. Now let's see the complications of meningitis, which can be acute and then also chronic. So acute sequelae are increased ICP, cerebral edema, seizures, SIADH, altered sensorium, subdural effusion, stroke, focal neurological deficits, CNS neuropathies like the the cranial nerves involved are 3rd, 4th, 7th, 8th. These are the common cranial nerves which are involved. Brain abscess, ventriculitis, shock and DIC. Then can be hydrocephalus, thrombosis of dural sinuses, ataxia, Waterhouse Federation syndrome seen in meningococcal meningitis, peripheral gangrene, carditis, arthritis, transverse myelitis, prolonged fever. So when you monitor, you should be watching for all these complications. Now come to the late complications. After discharge also, a child with a meningitis may develop some complications. So those can be permanent brain damage with a cerebral palsy, if the child is, especially if the child is younger than 2 years. Then can be hemiplegia, hearing loss or sensory neural deafness, mental retardation, recurrent seizure, secondary epilepsy, visual impairment like blindness, and then behavioral problems can occur, hydrocephalus, aphasia, mental retardation are some late complications. Now the conditions indicating poor prognosis. The highest mortality rate is seen in meningococcal meningitis, and prognosis is poor if the baby or the child is less than 6 months. If the seizure which is persisting after 4 days of illness, coma at presentation is bad, focal neurological deficit at presentation is high bacterial burden in CSF is poor prognosis, pneumococcal gram-negative etiology or pathogens are bad, CSF pleocytosis may be absent in overwhelming meningitis and sepsis. So if the patient is very sick and ill looking and the CSF is normal, pleocytosis is not seen, that is also a bad prognostic sign. Long duration of illness prior to antibiotic is bad. Late onset seizure after 4 days, seizure persisting for 4 days or seizure starting after 4 days of meningitis, both are indicating poor prognosis. Then shock, immunocompromised patient has a bad prognosis. Severe neurological neurodevelopmental sequelae is seen in 10 to 20% cases, and sensory neural deafness is very common sequelae, especially with the bacterial meningitis like pneumococcal or meningitis or Haemophilus influenza B meningitis. Now let's see the advice at discharge, what you should be advising. You should advise audiometry 6 weeks after discharge, because this is one of the big complications. And then you should be doing IQ testing, follow up with the head circumference measurement, seizure therapy, and then physiotherapy is important. These are the chemoprophylaxis and vaccinations in some meningitis. Like Neisseria meningitis, you should give chemoprophylaxis to the contacts. 5 to 12 years of age, you give single dose of ciprofloxacin, and younger than 5 years, rifampicin 10 mg per kg per dose 12 hourly for 2 days, and dose of rifampicin in neonate is 5 mg per kg. And then for this vaccination is 2-dose vaccine is available, which is a quadrivalent conjugate vaccine, and especially this is indicated in all children who is having a splenia or splenectomy patients. Post splenectomy, this is more important. Haemophilus influenza, if the child has, then you should give rifampicin 20 mg per kg per day once daily for 4 days to all contact less than 4 years who are not immunized or if they are immunocompromised. And Hib vaccine these days, it is available in the schedule at 6, 10, 14 weeks. Booster you can give at 15 to 18 months. Similarly, Streptococcus pneumoniae vaccine is available and given at 6, 10, 14 weeks with booster dose 15 to 18 months. Okay, thank you. Hope this class was helpful for you. Please like and subscribe and share so that you don't miss the other lectures. Thank you.